We are looking at a piece from My Adrenal Life today. It covers the cardiovascular effects of long-term cortisol replacement. It starts with the reality that gets glossed over in clinical settings, the sheer impossibility of untangling the disease from the treatment. When someone with adrenal insufficiency starts noticing changes, blood pressure swinging around, cholesterol creeping up, a different kind of fatigue, the immediate question is always whether it is the adrenal insufficiency itself failing to manage the body or the medication they take to survive.
That is a structural problem in how we talk about chronic illness. We treat the replacement hormone as a permanent fix, not an ongoing variable.
Cortisol is a massive variable. It gets colloquialized as just the stress hormone, but it governs vascular tone. It dictates how your body handles inflammation and manages fluid balance. When you lose the ability to make it natively, you lose a master regulator. The replacement we use, usually oral hydrocortisone, is a blunt instrument compared to the human adrenal gland. The adrenal gland is responding second by second. The pill is just a static dose. And the article gets into this beautifully. In a healthy system, cortisol follows a circadian rhythm. It peaks in the early morning to get you out of bed, gradually declines throughout the day, and releases in these tiny micropulses based on what you are actually doing. Standard replacement therapy cannot do that. You take a pill, you get a spike. A few hours later, you get a trough. Over years and decades, that exposure pattern, those artificial peaks and dips, starts to influence cardiovascular outcomes.
The mismatch between the human rhythm and the pharmaceutical rhythm creates collateral damage.
Collateral friction is maybe a better way to phrase it. The body is constantly trying to calibrate to a hormone signal that is shouting and then going completely silent. According to a review on cardiovascular risk in patients with adrenal insufficiency, this exact imbalance in blood cortisol can lead to a higher prevalence of coronary heart disease and major adverse events. It is the non-physiologic delivery that strains the system. The peaks mean the body is momentarily overexposed, and the troughs mean it is underexposed. Neither state is neutral. Neither is neutral. When you are overexposed, you get metabolic strain. Blood pressure can spike. When you are underexposed, inflammatory mediators actually increase. The body secretes more cytokines like interleukin-6 when cortisol drops too low. So the cardiovascular system is constantly navigating between inflammatory stress and metabolic stress multiple times a day.
That explains the fatigue the article mentions, the physical exhaustion of a cardiovascular system constantly trying to find baseline.
There is something almost sad about that when you think about what it feels like for the patient. You wake up, you take your medication, and you expect to just feel normal. But underneath, your vascular system is doing this intense, heavy lifting just to accommodate the delivery mechanism of the drug keeping you alive.
We should break down how this actually manifests. Blood pressure variability is the first major complication the article highlights. Blood pressure changes are incredibly common, but the underlying mechanics depend entirely on the type of adrenal insufficiency someone has. Primary adrenal insufficiency, which is Addison's disease, presents a very specific challenge because the adrenal glands are completely damaged. That means you are not just missing cortisol, you are also missing aldosterone. Aldosterone manages the sodium and fluid balance. It keeps the blood volume up. Without it, baseline blood pressure drops. People with primary adrenal insufficiency often deal with orthostatic hypotension, that dizzy feeling when you stand up too fast. The blood volume is literally too low to fight gravity effectively.
But wait, I am not sure that holds as a hard rule, because if they are taking replacement therapy for both, shouldn't the blood pressure stabilize?
You would think so, but the replacement for aldosterone is a synthetic mineral corticoid called fludrocortisone, and balancing it is notoriously difficult. If the dose is slightly too low, you stay dizzy and depleted. If the dose is slightly too high, you overstimulate the renin-angiotensin-aldosterone system, which can drive arterial hypertension. You swing from blood pressure that is too low to blood pressure that is artificially high.
The therapeutic window is narrow.
It is microscopic for some people, And remember, in a healthy person, aldosterone also follows a circadian rhythm, just like cortisol, but we replace it with a single daily pill. So again, we have a static treatment for a dynamic biological need. Secondary and tertiary adrenal insufficiency look different here. They do. In secondary and tertiary forms, the issue is at the pituitary or the hypothalamus, not the adrenal gland itself. The signal to make cortisol is broken, but the mechanism to make aldosterone usually remains intact. So the renin-angiotensin-aldosterone system is functioning. Their blood pressure is often more stable, but they still experience variability driven by those peaks and dips of their cortisol replacement.
Because cortisol still has a secondary effect on vascular tone, even if aldosterone is fine. Cortisol sensitizes the blood vessels to adrenaline. When your hydrocortisone dose peaks, your vessels constrict more easily. When the dose wears off, that sensitization fades. The My Adrenal Life article points out that this is why some patients feel perfectly stable at 10 a.m., but by 3 p.m. they are lightheaded and their heart is racing. It makes the standard medical advice to just eat less salt or exercise more seem misplaced.
The instability is baked into the pharmacology.
That makes me genuinely uncomfortable for the patients navigating this. They go to a cardiologist, and the cardiologist sees fluctuating blood pressure and treats it like standard essential hypertension. But it is not. It is endocrine-driven vascular variability. Treating it with standard blood pressure medications without adjusting the steroid replacement can sometimes make the instability worse.
Let us look at the metabolic side. The article mentions changes in lipids and cholesterol.
Cortisol dictates how the body processes fats and sugars. When you have long-term replacement, especially if the cumulative exposure is even slightly above what the body would naturally produce, the metabolic profile shifts. We see higher levels of LDL cholesterol and triglycerides.
The classic steroid side effects. We see this in its most extreme form in Cushing's disease, where the body produces massive amounts of cortisol. Exogenous glucocorticoid therapy can result in similar clinical manifestations, even at replacement doses over a long enough timeline. The body starts redistributing fat, usually to the center of the body, and the liver alters how it packages cholesterol.
I don't know, that feels too clean to me. Are we sure it is just the cortisol dose? Most people with adrenal insufficiency have other endocrine issues. Thyroid disease is heavily comorbid.
That is a crucial distinction. It is rarely just the cortisol. Autoimmune conditions like Addison's often cluster with Hashimoto's thyroiditis. If your thyroid function is sluggish, your lipid profile will look terrible, regardless of your hydrocortisone dose. But research specifically looking at glucocorticoid replacement shows that even independent of thyroid function, higher daily doses correlate with increased arterial stiffness and worse metabolic outcomes. The higher the dose, the stiffer the arteries.
And the lower the insulin sensitivity. One mechanism researchers have found is that higher glucocorticoid doses reduce insulin sensitivity, which then impairs nitric oxide activation in the blood vessels. Nitric oxide is what keeps vessels relaxed and flexible. So the cortisol causes a mild insulin resistance, which then causes endothelial dysfunction.
A cascade effect.
A very quiet, slow cascade. It is not happening overnight. It is the result of thousands of days of taking a medication that is slightly imperfect in its delivery. And that brings us to the debate in the medical community about which medication is actually best.
Hydrocortisone is the standard.
Hydrocortisone is the standard because it is identical to human cortisol. You take it 2 or 3 times a day, but because it drops off so sharply, some endocrinologists prefer prednisolone. Prednisolone has a longer half-life, so it provides a smoother curve of coverage throughout the day. Does a smoother curve actually improve the cardiovascular outcomes? The data is complex. Some studies suggest prednisolone once daily is more convenient and shows no significant difference in markers of cardiovascular risk compared to hydrocortisone. Other trials have actually found that patients switched to low-dose prednisolone saw a decrease in systolic blood pressure and improvements in patient-reported energy.
But prednisolone is technically a stronger synthetic steroid. It has more affinity for the glucocorticoid receptor.
It does, which is why the dose has to be tiny, usually 3 to 5 milligrams a day for replacement. If you overshoot that dose, the metabolic consequences are severe. There is also a push toward modified release hydrocortisone, which is designed to release slowly over the day, better mimicking the natural circadian rhythm. Early data shows it can actually lower plasma renin activity and stabilize sodium levels better than standard hydrocortisone.
Better delivery technology solves the peak and trough problem.
It definitely smooths it out. But access to modified release formulations is still limited by cost and regional healthcare approvals. So the majority of patients are still navigating the peaks and troughs of standard generic hydrocortisone, trying to micromanage their timing to avoid inflaming their vascular system.
Let us talk about the iatrogenic category, steroid-induced adrenal insufficiency. This feels like a paradox. It is the most common form of adrenal insufficiency and the most medically complex. These are patients who are prescribed steroids, like prednisone or dexamethasone, for a different condition: rheumatoid arthritis, asthma, inflammatory bowel disease. They took high doses for a long time, and their brain simply stopped telling their adrenal glands to work.
The medication that caused the adrenal suppression becomes the medication required to sustain them.
Exactly, and their cardiovascular risk profile is heavily influenced by that prior exposure. When you take high-dose steroids for an autoimmune disease, you are fundamentally altering your lipid metabolism and your vascular health. The National Institute for Health and Care Research published findings showing that even low daily doses of prednisolone, under 5 milligrams a day, can double the original risk of developing cardiovascular disease over a year.
Wait, does that actually hold? Because 5 milligrams of prednisolone is generally considered a physiologic replacement dose for someone who makes 0 cortisol. Are we conflating people with active inflammatory disease with people who just have adrenal insufficiency?
That is the exact tension in the literature right now. It is incredibly hard to separate the risk caused by the steroid from the risk caused by the underlying inflammatory disease that required the steroid in the first place. Systemic inflammation destroys blood vessels. Rheumatoid arthritis alone dramatically increases heart attack risk. But the current consensus is that the glucocorticoids themselves add an independent layer of cardiovascular risk, even at lower doses.
The risk is cumulative, regardless of the initial trigger.
The body remembers the exposure. If you had 5 years of high-dose prednisone for asthma before your adrenal glands suppressed, your blood vessels have weathered 5 years of supraphysiologic metabolic strain. When you finally taper down to a replacement dose, you are carrying that cardiovascular history with you. It doesn't reset to 0.
The article emphasizes that risk does not equal outcome. It feels necessary to state that clearly, otherwise this research just reads as a threat.
The statistical trends describe populations, not the individual sitting in the doctor's office. You read that adrenal insufficiency carries an increased rate of cardiovascular disease, and it is easy to internalize that as a predetermined fate. But the variables we just discussed, the dosing, the timing, the fluid balance, the thyroid management, those are the actual levers dictating the outcome.
It requires shifting the goal from fixing the disease to managing the system. The article offers practical ways to support cardiovascular health without demanding perfection.
Because perfection is impossible when you are manually running an endocrine system. The article talks about gentle, consistent movement, not high-intensity interval training that floods the system with a demand for cortisol you cannot produce, but movement that supports circulation without triggering a crisis. Pacing and energy awareness become cardiovascular interventions, avoiding the boom and bust cycle of exertion. When you overexert and crash, you are severely dipping your cortisol levels, which triggers those inflammatory cytokines we mentioned earlier. By keeping your energy expenditure relatively stable, you are actually protecting your vascular lining from those inflammatory spikes. It is a completely different way to think about pacing.
Hydration and electrolyte balance take on a mechanical importance, especially for primary AI.
In primary AI, salt is basically a prescription. If your blood volume drops because you aren't retaining sodium, your heart has to work harder to pump a smaller volume of blood. That tachycardia, that racing heart patients feel, is often just the cardiovascular system screaming for fluid and sodium. Staying ahead of that deficit reduces the mechanical strain on the heart.
This conversation changes how you view a changing lab result. A shift in cholesterol isn't necessarily a failure of diet.
It is often just a reflection of the systemic approximation. The body is doing its best with an imperfect replacement. If the labs shift or the blood pressure gets weird, it means the system is complex, not that the patient is doing something wrong. That reframing is so vital for the mental health of anyone living with this.
It removes the moral weight from the symptoms.
Adrenal insufficiency asks a massive amount of the person living with it. You're constantly acting as your own pancreas, your own adrenal gland, trying to calculate stress and output. The cardiovascular effects are just the physical footprint of that ongoing calculation. Understanding the mechanics allows you to advocate for better dosing, maybe trial a different medication like prednisolone or modified release hydrocortisone. But it also allows you to give yourself some grace.
The complexity is the reality. It is a system requiring daily adaptation.
And there is a lot of ongoing research trying to build better tools for that adaptation. If anyone listening wants to read the full article we dissected today, or dig into the specific studies on modified hydrocortisone and lipid profiles, they are all posted on the My Adrenal Life Facebook group.
Go join the discussion there. Share this episode with anyone trying to make sense of their own endocrine health.